This lesson will explore special populations in cardiopulmonary rehab and their implications for the respiratory therapist. We will also focus on medical and legal considerations for all cardiac rehabilitation programs. Special patient populations may need additional monitoring and support. Of special interest for the respiratory therapist are patients with COPD in addition to CVD. They should be continuously monitored for desaturation during exercise and instructed in pursed lip breathing exercises. O2 may need to be titrated and dyspnea scales utilized. Use of upper extremity support with exercise, such as holding the bars of treadmills, stationary bikes, and rolling walkers, may stabilize accessory muscles. Smoking cessation, if needed, is a critical part of the rehabilitation program. Other special populations include patients with multisystem issues, women, children, and the elderly, patients with peripheral arterial disease, patients with diabetes mellitus, and patients who have had a stroke or have renal disease. For each special patient population, there are specific areas to focus our attention when developing an individualized program. For instance, patients with peripheral vascular disease should be given walking rest cycles and watched for signs of claudication, which is pain in the calves, much like angina in the chest. If they are cigarette smokers, a smoking cessation program should begin immediately, and other cardiovascular risks addressed. Patients with heart failure are now considered candidates for cardiac rehab even with ejection fractions less than 35%. Studies have shown that in addition to reduction in risk factors, improved endurance, and improved quality of life, exercise may have the ability to reverse left ventricular remodeling, increase ejection fraction, and improve mitochondrial function. Perceived exertion and dyspnea scales should be employed, and patients need to be instructed to weigh themselves daily. Any rapid weight gain, 3 to 5 pounds over a few days, lower extremity edema, and dyspnea should be reported to the physician. Patients with diabetes are 3 times more likely to have CAD than those without diabetes. In addition, 80 to 90% of type 2 diabetics are obese. Therefore, exercise and diet and nutrition are crucial for improvement of risk factors. Hypoglycemic episodes need to be watched during or after exercise and for the next 24 hours. Some form of simple carbohydrate should be readily available, such as sugar, juice, or glucose. Diabetic patients on beta blockers, however, may not show the symptoms of hypoglycemia due to blocking of the sympathetic system. Patients who have experienced cerebrovascular accidents may present with impaired cardiac function and must be monitored intensely, specifically blood pressure and heart rate. Special accommodations should be provided to those with impaired communication. Patients with renal disease also benefit significantly from regular exercise programs, but again must be heavily monitored, and exercise to rest ratios should be 1 to 2. Heart disease in women is a special category due to its underdiagnosis and undertreatment. Certainly, women benefit greatly from cardiac rehabilitation, with improvements in all domains similar to men. However, women are less likely to enroll in cardiac rehabilitation, and their dropout rates are higher than men. This may be mitigated if programs are designed for women only. Therefore, separate times for men and women in the rehabilitation program may encourage compliance. The elderly patient also presents a challenge, as many who have not exercised in the recent past have low expectations and sometimes negative attitudes towards the rehabilitation process. Exercise, however, can promote a sense of well-being and heightened self-esteem, both essential components to independent living. Our last special population is pediatric patients. We will reserve further information about this group in our next lesson. Our last topic of interest in this lesson is the importance of documentation and record keeping and medical and legal concerns. Proper documentation and record keeping are essential for evaluating the value and validity of a rehab program and assuring quality. The contents of proper record keeping include an attending physician referral and authorization, pertinent medical data, initial evaluation, regular progress notes, monthly reports and log records, and a discharge summary. Lastly, medical and legal considerations should also be noted. Legal concerns generally fall into 2 aspects of the program. They are adverse effects of medically prescribed exercise testing and fitness conditioning, and consideration of disability pension and insurance benefits that may influence the patient's motivation to return to work and may affect the attitude of an employer toward a person with a quote-unquote heart problem. It is important to always properly supervise and monitor the patient, and know when to terminate a session when potentially dangerous situations arise, and there must also be adequate advanced preparation and training for emergencies in accordance with generally accepted medical standards.